The patient that I will be giving a report on was in room 1419 on the 4th floor of Wesley Long Hospital. Thomas Wilkins is a 60-year-old male who came from home and will be going back home with hospice services when discharged. He is a DNR. He was admitted on Wednesday, March 18th with a chief complaint of pain related to malignant ascites, nausea, and emesis. He vomited up his Cipro and pain medications that morning. The day before admission, on March 17th, he had a permanent drain, also known as an Aspira drain, placed in the right lower quadrant of his abdomen due to recurrent fluid buildup. The patient has colon cancer, which has metastasized to his lungs and liver. After reviewing his labs, it was clear that Mr. Wilkins was in acute renal failure in addition to liver failure. BUN was elevated to 36, GFR was low at 89, however creatinine was within normal limits. His white blood cell count was trending up from 15.3 to 18 within a couple of days, indicating a possible infection. Red blood cell count and hemoglobin remained low due to excessive amounts of bloody drainage from the peritoneal cavity. There was also a hematoma forming on the patient's right side of his stomach with some edema present as well. He received 2 units of packed red blood cells on March 19th. Mr. Wilkins weighs 150 pounds, which is equivalent to 68.4 kilograms. He is 6 feet tall. The patient's vital signs remained stable throughout his hospitalization. Allie and I made sure to check his blood pressure after draining the ascites fluid from the Aspira drain to make sure that he was tolerating it well. His blood pressure remained stable around 120/70 most of the time. He was in normal sinus rhythm on telemetry and between 97 and 99% oxygen saturation on room air. Mr. Wilkins has a right chest portacath from a previous chemotherapy treatment regimen. We ran normal saline at KVO through it to ensure patency. Again, looking at his white blood cell count, it is possible that the patient might be showing signs of infection. Also, due to recent chemotherapy treatments, his immune system is weakened, and that makes him more susceptible to get infection and harder for his body to fight infection. Due to the patient's low red blood cell and hemoglobin levels, there is reason to think that bleeding is occurring somewhere in the body. However, it has not been confirmed yet. The bloody drainage coming from the peritoneal cavity is another reason to suspect bleeding. Again, Mr. Wilkins was between 97 and 99% oxygen saturation on room air at all times, indicating adequate oxygenation throughout the body. Upon assessment, his capillary refill was less than 3 seconds, showing good perfusion to the extremities. The patient was a moderate fall risk, needing 1 assist when getting up for any reason. He was able to get up and go to the bathroom with minimum assistance. However, he remained in the bed for the majority of his hospitalization. It seemed to be where he was most comfortable and able to get the most rest. The patient states he has been in pain ever since the procedure was performed the day before admission with placement of the Aspira drain. The pain decreased when the fluid was drained off of the abdomen each time. The day before he presented in the ED, the hospice nurse drained off 1 liter of fluid. Another liter was drained in the ED around 11:30 that morning. At that point, the patient's wife and the nurse that was draining the fluid off grew concerned because the fluid had turned to a darkish red color compared to the normal color that it seems to be, which is a yellowish brown color. The doctor ordered a CT scan upon admission. The results were the following. Metastatic colon cancer, multiple nodules in the lung bases were found compatible with metastatic disease. There is diffuse metastatic disease throughout the liver, and calcification is also present. There's a moderate amount of ascites, which we have talked about, and that's why the Aspira drain was placed, some of which is hyperdense with blood, bilateral lung metastasis, and hemoperitoneum with a moderate amount of bloody fluid in the peritoneal cavity. In addition, after the fluid removal in the ED, a sample was sent for analysis and the cultures were negative for bacteria. After adequate education was provided to Mr. Wilkins by the healthcare provider, he verbalized that he understands the terminal nature of his illness and diagnosis and is only looking for pain management at this time. Mr. Wilkins is very good. He has a very good home support system and spiritual support system as well. The medications that he takes at home, he is currently taking hydrocodone 10 milligrams once daily for abdominal pain. His last chemotherapy treatment was on January 23, 2015. The doctor prescribed the following medications for the length of Mr. Wilkins' stay in the hospital. Hydrocodone acetaminophen, also known as Norco, 1 tablet every 4 hours for moderate pain. He was also able to have hydromorphone or Dilaudid IV every 4 hours PRN for severe pain. And this is what Allie and I discovered seemed to work most effectively for this patient. He seemed to be able to rest a whole lot better after getting the Dilaudid compared to any other pain medication that we could give him. Also, he was able to have Zofran 4 milligrams tablet or IV every 6 hours PRN for nausea. Aside from pain, Mr. Wilkins was uncomfortable due to the fact that he had not been able to have a bowel movement for several days. So we gave him Senokot 2 tablets PRN for constipation, and milk of magnesia was also available daily to help relieve the constipation, and a one-time fleet enema was ordered as well. After the Senokot and the milk of magnesia failed to work together, Allie and I decided to give him the fleet enema after he had okayed it. He was good. He wanted to have it because he was ready to have a bowel movement. And sure enough, it was successful. He was able to have a bowel movement, and he reported feeling a lot better after doing so. So that was good. Mr. Wilkins was also prescribed ceftriaxone or Rocephin IV piggyback every 24 hours to prevent spontaneous bacterial peritonitis, and that is an acute bacterial infection of the excess fluid that has gathered in his peritoneal cavity. Due to the patient's condition of liver failure, the doctor wanted him to have a dose of lactulose twice daily due to the potential ammonia buildup in the body. And this medication, it works by removing the ammonia from the stool in an attempt to prevent confusion, which is a side effect of ammonia buildup. And this medication seemed to be working very effectively because he was alert and oriented ×4 throughout his entire hospital stay. So he was not having any problems with that. Also, there was great collaboration between the hospitalists, the nurses, lab, pharmacy, and oncology when it came to providing Mr. Wilkins with care. They all kind of gathered together and worked as a team to provide him with the best care possible and to keep him as comfortable as we possibly could, since that was our ultimate goal here. Because there was really nothing else that we could do and nothing else that he wanted done besides just keeping him comfortable here. And we were doing the best to figure out how to do that for him. Also, by looking at this patient, it was obvious that he had lost a great deal of weight due to his health condition and his he's just really went downhill fairly quickly. His collarbones were very prominent and his eyes were sunken in a little bit. And throughout the time that Allie and I spent with him, we both noticed that he didn't eat much at all. And the dietitian ordered a nutritional supplement for him called Resource Breeze twice a day for nutritional support, obviously. And sometimes he would drink it, other times he wouldn't. It just kind of depended on how comfortable he was as far as the tightness in his belly. And, of course, after he had a bowel movement, he was more eager to eat and get fluids down. So it was clear that his level of comfort really affected his appetite and how much he was willing to eat or drink. Also, this is the sheet that I'm going to share whenever I give my actual in-person speech. It's the sheet that we use on the unit for report. Each nurse is required to use it, and it kind of is just a general rundown of everything that you need to know about each patient that you're taking care of, and it's a really good guide as far as knowing, okay, I didn't miss anything, everything's been covered, and it's written down for the next oncoming nurse. Okay, thank you.